When is behavior not behavioral? Recognizing neurologically driven behaviors in children with autism spectrum disorder. Children with normal development often manifest challenging behaviors. For example, children with normal development may manifest disruptive behavior as a means of gaining attention, escaping from a task, or in an effort to obtain a desired object or activity. Children with developmental disorders also manifest challenging behaviors. On the surface, many of these behaviors resemble those seen in children with normal development. Unlike the behaviors of children with normal development, however, the challenging behaviors in children with developmental disorders are often neurologically driven and may be partially or completely out of the child's control. In this presentation, we provide a brief overview of neurologically driven maladaptive behaviors in children with developmental disorders, with an emphasis on behaviors in children with autism spectrum disorders. The symptoms of autism spectrum disorder include impaired social reciprocity, impairment of vocal pitch and the communicative function of language, repetitious behaviors, and impaired sensory processing. In order to understand maladaptive behavior in autism spectrum disorder, however, a more useful way to think about autism spectrum disorder is to consider some of the underlying neuropsychological deficits. Neuropsychological deficits in persons with autism spectrum disorder include cognitive rigidity, abnormal regulation of attention, abnormal regulation of arousal, abnormal regulation of sleep, and abnormal regulation of sensory processing. Each of these underlying deficits contributes to the clinical picture. Understanding the neuropsychological basis for maladaptive behaviors in children with autism spectrum disorder enables us to address these behaviors in an informed, proactive manner rather than just reacting to symptoms after they have occurred. It's useful to think of these neuropsychological deficits arranged around the perimeter of a circle, like numbers on the face of a clock, with cognitive rigidity at 12 o'clock, regulation of attention at 3 o'clock, regulation of arousal at 6, regulation of sleep at 7, and sensory processing at 9 o'clock on the dial. Each of these underlying neuropsychological deficits can contribute to the emergence of agitation, aggression, and disruptive behavior, which we place at the center of the dial. Unlike board games, where the object of the game is to get to the middle of the board, in autism spectrum disorder, the object of intervention is to reduce the likelihood of tumbling into the center of the circle. Cognitive rigidity refers to difficulty shifting mental sets. The brain is sticky, and the person's thoughts and behaviors have a black and white, all or nothing quality. Think of the scene in Rain Man, where Raymond has to see Judge Wapner. This is not the ordinary demanding behavior of a spoiled child. This is neurologically driven behavior over which the character in the movie has little or no control. If an individual with autism spectrum disorder cannot complete some anticipated routine, or if events aren't working out exactly as expected, he or she can become extremely upset. In the movie Rain Man, Raymond becomes so upset that his brother has to pull the car over and knock on a stranger's door, explaining to the startled occupant, "My brother has to see Judge Wapner." When working with a person on the autism spectrum, it is essential to distinguish between ordinary stubbornness and this type of neurologically driven behavior. There is more to cognitive rigidity than just sticky brain. Many of us played with one of these when we were kids. We would ask the 8-ball a question, then turn it over and look in the little window on the bottom to see what answer floated up. Yes, no, I can't tell you now, and so forth. Like the magic 8-ball, cognitive rigidity includes not only insistence on sameness and difficulty with transitions, but perfectionism, task avoidance, if the person is afraid they cannot complete a task perfectly, obsessions, and compulsions. Any of these behaviors can float up in the little window. Anxiety and/or depression are the silent partners of cognitive rigidity and frequently go unaddressed until they boil over into disruptive behavior. Here is the way one of my patients meticulously arranged all of the blocks in my waiting room. His perfectionism was so intense that he became intensely agitated and disruptive whenever he could not complete a school assignment perfectly. Here is a drawing by a patient of mine with autism spectrum disorder plus disabling anxiety. She filled page after page of her sketch pad with pictures of snarling dogs and frightened people. She was barely able to venture out of her house without becoming intensely anxious. Next, let's consider abnormalities in the regulation of attention, which we have located at 3 o'clock on the dial. Ordinarily, we shift back and forth effortlessly between different stimuli in the environment. This process requires us to let go of our attention to the first stimulus, like a trapeze artist tumbling through the air, and then grab on to the second stimulus. We are constantly alternating between attending and letting go. In autism spectrum disorder, however, the ability to shift back and forth is impaired. Instead of alternating smoothly between attending and letting go, the person's brain can become stuck in one phase of this process or the other, leading to either perseveration or inattention. Perseveration has a mechanical, automatic quality about it. Like the Energizer Bunny, perseverative behavior just keeps on going and going. The parent of one of my patients with perseveration wrote, "My child has over-attention deficit disorder." In contrast, cognitive rigidity has an emotionally insistent quality. Rain Man had to see Judge Wapner. Perseveration amplifies the effects of cognitive rigidity. Here is a family drawing produced by a 4-year-old with normal development. And here is a family drawing produced by an 8-year-old boy with autism spectrum disorder plus severely perseverative behavior. He kept going and going until I gently told him we were about to run out of time. Sometimes it is not so easy to get a child with perseveration to stop. Completely opposite to perseveration, some children with autism spectrum disorder have an inability to focus, which mimics attention deficit hyperactivity disorder. Often, the same child will shift back and forth between perseveration 1 minute and inattention the next. Before entertaining a diagnosis of ADHD in a child with autism, however, beware of anxiety and cognitive rigidity masquerading as ADHD. Perseveration on inner stimuli, perfectionism, and anxiety can create a clinical picture that looks exactly like ADHD. However, the behavioral and medical interventions are completely different. Next, let's consider abnormalities in the regulation of arousal. We all go back and forth between a calm and relaxed state, shown in the middle of the diagram, and states of decreased or increased arousal. If we feel endangered, as on the right side of the diagram, our arousal level increases and we enter fight or flight mode. At the other end of the arousal spectrum, for example, after a big Thanksgiving dinner, our arousal level decreases. Ordinarily, these transitions are smooth and gradual, but as with dysregulation of attention, many children with autism spectrum disorder have abnormal regulation of arousal. Some children with autism spectrum disorder have a reduced threshold for arousal. These children go into fight or flight mode after minimal provocation or sometimes for no apparent reason at all. Parents of these children often say they feel like they are walking on eggshells. They never know when or what will trigger an outburst. Often, hyperarousability is accompanied by difficulty with regulation of attention. The child may be both impulsive and easily agitated, a challenging situation. To make matters even worse, children with poorly regulated arousal also commonly experience poor regulation of sleep. This results in a child who is hyperarousable and hyperactive by day and sleepless by night. It is not uncommon for these children to take an hour or more to fall asleep. Often they awaken at 3 or 4 in the morning, ready to greet the new day. This is an extremely difficult situation. Fortunately, there are medications and behavioral interventions that can help. Finally, let us turn to sensory processing. Sensory processing tells us whether a given stimulus is familiar or unfamiliar, pleasant or unpleasant, originating within our bodies or coming from the outside, and calls up a myriad of associations. Just as new car smell may evoke a pleasant memory of your first car, or a particular song may evoke a recollection of your first date. Sensory processing is also connected to one's sense of self-awareness as a person and one's ability to feel empathy for others. Just like regulation of attention and arousal, regulation of sensory processing can go off-kilter in 2 different directions. Some children with autism spectrum disorder have a reduced sensory threshold. That is, they are hypersensitive to environmental stimuli. For these children, sensory overload can lead to a meltdown. Other children have an increased sensory threshold. For these children, ordinary stimuli seem blunted and remote. They may engage in sensory-seeking behaviors to satisfy a craving for sensory input, such as licking, chewing, squeezing into tight spaces, or crashing into walls, all the way up to self-injurious behavior. Often, the same child may have sensory-seeking behavior for some kinds of stimuli and sensory-avoidant behavior for other stimuli. As this diagram suggests, a child on the autism spectrum may have behavioral challenges in multiple areas simultaneously. It is the adult's job to figure out what's going on, why, and to address the root causes, not just the symptoms. Admittedly, this diagram is complicated, but this is the world Mother Nature has given us. To quote Albert Einstein, everything should be stated as simply as possible, but no simpler. In this presentation, we have listed some of the neuropsychological deficits that occur in children with autism spectrum disorder and some of the maladaptive behaviors that stem from those deficits. We hope this presentation will underscore the fact that not all maladaptive behavior in autism spectrum disorder is behavioral in the ordinary sense of the word. That is, some behaviors are neurologically driven and may be partly or largely beyond the child's voluntary control. The same is true in other neurodevelopmental disorders, such as OCD or Tourette's syndrome, where tics, obsessions, and compulsions may also be largely or entirely beyond the child's voluntary control. Treatment is beyond the scope of this presentation. However, there are a variety of behavioral interventions and medications that can modify, reduce, or in some cases eliminate many of the maladaptive behaviors we have described here. Many times, the combination of behavioral intervention plus medication works better than either modality in isolation. In this brief presentation, we have only been able to scratch the surface. We have listed additional sources of information on our website and in our book. For additional information, go to www.drcoplan.com. Thank you.